Good afternoon, everyone, and welcome to the Communicating with Confianza Health Literacy Echo series. My name is Dr. Raquel Romero, and I want to be the facilitator for the Echo session today. This session is brought to you by Health Confianza team in collaboration with the UT Health San Antonio Super Hub, the YMCA, South Central EHEC, and the University of Texas at Austin. Please let me start by saying that Health Confianza is a community-wide health literacy program that aims to provide health literacy education, training, resources, and workforce development for Bejar County and the surrounding areas. Confianza is the Spanish word for trust. Our team believes that health literacy is critical to transform health and to achieve health equity for all. With the goal of increased health literacy in our communities, these sessions were carefully planned to equip with tools and skills to those who attend the session. And we may have different reasons to join the session, but there is one consistent thing that I believe brings us close together, and it's a deep desire to have a deep understanding of health literacy. It's very important each session builds upon each other. So I invite you to explore what we have to offer in the following session. So thank you so much for your support and the trust on us. For those that are new for the ECHO platform, ECHO stands for Community Extension for Community Health Outcomes. It's a virtual training mentoring stage specifically designed to create connections between communities and subject matter experts. ECHO sessions have the following components. We begin with the welcome, and then we do the introductions and announcements. We have a didactic, and then we have a case presentation. And we invite you to be part of the discussion during that time. And please remember that no personal health information is allowed to share at any point in this session. So what is personal health information? The OBs, date of birth, addresses, appointment dates, etc. So now before we go to the introduction for the Confianza team, there are a few technical points that I need to mention. And to help us with attendance records, please enter your full name, your affiliation, and the email address in the chat box. And please stay muted unless you are speaking, but we promote interaction, so we invite you to be part of our discussion. And if you feel comfortable and you're able, we invite you and encourage you to join us by video, particularly in the discussion part of the session. If you have any connection issues, please contact us or send a message to the ECHO IT for assistance. So let me move with the introductions. So let me see, I will start with Dr. Brown, didactic presenter today. Would you please unmute yourself and introduce yourself?
Absolutely. Thank you so much, Dr. Romero. So my name is Cristal Brown. I am a physician scientist. So I am trained as a transplant hepatologist, which means I care for patients who have any form of liver disease, but for those who have more advanced liver disease through the liver transplant process. And I am a faculty member at Dell Medical School in UT Austin. And I have the privilege today of talking about identifying and removing shame and blame from clinical practice. And part of this is very near and dear to me. As a scientist, I have recently gotten a research award to look at stigma in chronic liver disease. So stigma is something I think about every day in my clinical practice, and I'm really privileged to have the opportunity to talk about it today.
Thank you very much, and we're triggered to learn more about it. As a part of our hub team, we also have Dr. Rosenfeld.
Good afternoon, everyone. I'm Jason Rosenfeld. I'm an associate professor, Department of Medicine here at UT Health San Antonio, and I co-direct the Health Confianza program. Good to see you all.
Thank you very much. Dr. Stone.
Good afternoon. I'm Melanie Stone, Assistant Professor in our Department of Family and Community Medicine at UT San Antonio and co-direct Health Confianza, and very excited to have Dr. Brown join us today. I've gotten to know her over the past, 6 months, and I think we're in for a very good presentation today, so looking forward to it.
Thank you very much. And we have Dr. Adelita Cantu.
Good afternoon, everyone. My name is Adelita Cantu. I'm a professor at UT Health School of Nursing and have worked with Dr. Stone and Dr. Rosenfeld with Health Confianza for the last few years. Excited to hear Dr. Brown's talk today. Thank you.
Thank you very much. And today we have Gloria Barrera, is the case presenter.
Hello, thank you so much for allowing me to join. I am a certified school nurse and am joining from Chicago, Illinois. Thank you.
Thank you very much. Thank you for the case presentation today. As a quick reminder, towards the end of the session, our team will send you a link for the CMEs, and evaluation of this session should be patient with us. It's taking a little bit of time for us to receive and send the certificates. But these sessions are possible because of you, and your feedback is so important for us. So finally, I would like to mention that ECHO is all teach, all learn environment. We encourage you to share your experience, your comments and questions through the session today. So with no more from my end, I would like to move to didactics. Dr. Brown, on your time. Thank you so much.
Absolutely. Okay, so I have no relevant conflicts of interest or any financial disclosures relevant to this presentation. So it is my goal that at the end of this presentation that everyone will be.
Dr. Brown, you want to share the slides? Do you have a?
Oh, are there not? I'm sorry.
No,
yes, we will share the slides. Let me go back.
Thank you very much. Thank you.
That would be important. There we go. Okay, can people see my slides?
Thank you.
Awesome. Very good. So let's try that again. So no relevant conflicts of interest or financial disclosures. And so for today, my learning objectives for the end of this presentation will be that attendees will be able to identify 3 domains of health-related stigma and understand their impact on healthcare delivery, and also to be able to apply some practical skills to your routine healthcare practice to minimize health-related stigma. So I just wanted to start with a definition because there's a lot of definitions of stigma that are out there. And what I chose to kind of speak a little bit about and frame this talk comes from kind of very well known in the scientific literature, Doctors Link and Phelan, who published their conceptualization of stigma back in 2001. It's one of the most cited definitions in scientific literature. And what they thought about was these 6 conditions that need to be present to actually create stigma. And they did this because they wanted a way for us to actually be able to research and think about the prevalence and the consequences of stigmatization, particularly in a healthcare setting. And so they started off by talking about labeling human differences. And I think that that's, pretty obvious. For us, there's many physical differences that we could think about. If we look at each other, even right now, we can see some of those differences. And then things like our medical conditions, we can always label people as being different. But where stigma comes in is when we begin to stereotype and create these negative messages related to those differences. And so all of a sudden, a medical condition, a skin color, someone's social circumstance can then have a negative connotation. We then go on to separate us from them. So us being those who do not have this difference, and then them who have this difference that we have now called negative. And then there's discrimination. So based on the fact that this person is different, we are going to treat them different. And I think one of the hallmarks of this definition is that they really talk about the power dynamic. So the people in the group of us have some type of power over them. And I think in healthcare, that's very clear, right? As a provider, as someone who has access to resources, and with our patients, there is just an inherent power difference that is there. And then there are emotional reactions, both on the side of us and them. So generally us having these negative reactions to the patient or the person that has the kind of undesirable difference. And then that person with the undesirable difference really feeling that stigma. So feeling the blame, the shame. So I like this definition because I think it encompasses a lot of the condition and things that have to kind of come together to be able to create stigma. And so when we think about this from a healthcare perspective, back in 2002, they created this medical condition regard scale. And it's kind of cleverly done. It was a group they took medical students, so over their 4 years of medical school, and they actually pilot tested 18 questions. And these questions were meant to be non-disease specific. So just questions about how we feel bias and stigma related to different conditions. And they actually looked at 12 different medical diagnoses and then 2 psychiatric diagnoses over the 4 steps of this. And so they did first 2 exploratory steps and then went on to do a validation and a reliability testing. And what you see on the right side here are the 11 questions that they came up with. And so it's interesting because what they did when they created this regard scale is that you could have a provider answer these questions about various diseases and get an understanding about what diseases did providers like or not mind taking care of, as opposed to those that they disliked. And so they looked at the desire to work with certain patient populations, how treatable we felt like those individuals were, and then the worthiness of medical resources. And when they say worthiness, I think the thing that really stood out to me there was the question, I wouldn't mind giving extra time or effort for caring for patients like this, or treating patients like this is a waste of medical dollars. And so with this type of information, we were able to understand who are some of the more highly stigmatized populations. And so I think it's no surprises here on this slide. So mental health disorders, individuals with persistent substance abuse, obesity, HIV and AIDS, and chronic liver disease. So certainly not a comprehensive list, but some of the more stigmatized conditions when we think about the healthcare system. And so I think it's really important that we try to contextualize this in our own clinical practices. And I think that that's where, when I started thinking about this from a research perspective, it really made me think about my clinical practice and the things that I was seeing. And I think a great place to start is within ourselves and our implicit bias. So most of us have probably done some formalized implicit bias training, but here we're just talking about what are those conditions or what are those things that kind of make you take that extra sigh when you see that this patient is coming or this medical condition you're going to have to manage. What are the things that you start to have that negative attitude toward? And then just recognizing that there are some negative attitudes, and I'm sure we can talk about this a little bit more in the discussion aspect of things, but we can see some of these things very systematically in how we treat patients and the resources that some patient populations receive compared to others. So looking at these very negative attitudes that can come towards certain patient populations. Also, the barriers to care. And some of this is we don't always have a lot of control. So I have here limiting access based on insurance status. So, we can't necessarily control the insurance that someone has. But the things that we do have control over are what are the resources that we provide. So sometimes it takes extra steps to compile resources, to know what our local resources are, working with case managers, community health workers, social workers, to be able to find means of taking care of these patients in optimized ways. And so that's where, if we don't necessarily like a certain group, we may not work as hard to ensure that they get access to things if it's not easy to do. And then not offering potential treatment options. And in my world, I think about this a lot from a transplant perspective. So I see a lot of patients who are not referred to liver transplant and don't even have a chance for evaluation. And when I look at the notes or I talk to providers and ask why, there's not always an objective reason. It's something subjective, like they're not really compliant. They don't do the things that we ask them to do. I don't think they have strong social support, but nothing that's an absolute barrier. And these are the kind of things that can create very negative health consequences for stigmatized patients. And then lastly, just using stigmatizing language. And we're going to talk a little bit more about that in a few slides. So I think examples are great. And so I wanted to highlight a couple examples, two from healthcare provider statements and then two from patients. And so we'll start with the healthcare provider statements. And I think this is very telling. Like when I was going through and trying to find some of these, the fact that someone felt confident enough to say this in an interview and then for it to be published tells me, and these are the things that they were okay with saying. You can imagine how people have some of these attitudes, but don't necessarily say it. And so the first one's a primary care provider who they were talking about discussions for caring for obese patients. And the provider said, you can lead a horse to water, but you cannot stop it from eating cream cakes. And I think, it's a little bit funny, and you can say this as an offhand comment. But the danger here is that if this is the attitude that you have about treating someone that has obesity, then you probably are not going to work as hard to get nutritional training, to talk to them about their lifestyle choices, and to really create a therapeutic alliance, which is going to optimize the care for the patient. You already think that they are not going to follow your instructions. And so what is the point of taking that time? And then the next one is a consultant gastroenterologist, and this was just talking about difficult patients in general. And there they said, generally speaking, during the training years, it is a difficult group. Patients were time wasters who we can't help, who are difficult to get through. And I think once again, if you bring this type of attitude when you walk into a patient room, you're not going to be open to understanding what their challenges have been. How can you really navigate those things and help them? And these types of labels and this type of kind of stigmatizing of patients, even before we walk in and see them, creates significant negative healthcare consequences. So then when we look at it from the patient side of things, I chose a patient who has chronic liver disease and has a diagnosis of autoimmune hepatitis. And for this patient, they had to actually go to their place of work to get treatment. And they said, I got admitted in the unit where I work. One of our pulmonary doctors went around asking my friends and other coworkers whether I drink alcohol or not. When told that I don't and never drink, he insisted maybe I was a closet drinker. And this is something that's very near and dear to me because when I take care of these patients with liver disease, one of the first things that I hear most often is patients like, I'm not a drinker, I don't drink alcohol. And that's because of this type of stigma that comes with a diagnosis of chronic liver disease. And I can just imagine what it would feel like to go to your place of work and have this conversation. And now people are questioning your lifestyle behaviors for a diagnosis that you actually have no control over. And then finally, I took a quote from a pregnant patient who had a substance use disorder. And here she states, while giving birth, so I felt like they manhandled me a lot. More so than a woman delivering that was a sober female. I didn't bother going back because I didn't like their treatment. And this really, I feel like, encapsulates the problem. If we alienate people so much and treat them in such a way that they don't want to come back for care, this is the patient who needs more care, who needs resources to help achieve and maintain sobriety, whose newborn needs to be evaluated for complications and consequences of substance use. And yet she doesn't feel comfortable coming back because of the way that she's treated. So with all of these examples, I just want to highlight the fact that they have really important implications for people's desire to access healthcare and their future care. And so we talked a little bit about the importance of word choice and terminology. And I will say, and I will be the first to admit, I think I have used either in my verbal communication or written communication, all of these words at some point in time, because I think that they are very common medical terms that many of us may have trained and learned. But, things like abuse and addict and alcoholic, many of my diagnoses still contain the word alcoholic, even though I try not to use that anymore. Elderly, fatty liver, handicapped, homeless, homosexual, illegal immigrant, obese. These are things that, even though they may not mean a lot to us, they mean a lot to the patient. And so we can really fracture our therapeutic relationships with patients when we're using these words. And we also have to be mindful it's not just what we say to them, but patients have a lot more access to our notes. And so if we're using these terms in our notes, then patients may see them and really be offended. We also have a lot of words and statements that can assign blame, and some of that may not always be so overt. But when we put things like the patient claims that the treatment didn't work, or that they're non-compliant, they've complained, they failed, they refused, these notes are our communication to other providers at the very least, and sometimes other people see these notes as well. And so it creates a stigma about who this patient is when we use these type of words and we blame, instead of saying the patient didn't take their medication because they have financial constraints or they had side effects. And so putting all of these things together, I really like this conceptual model because it looks at stigma not only from the people who are experiencing it, but also from a provider and an organizational level, but then delves into what are the consequences of that. So with people who are stigmatized, they can have anticipated or perceived stigma. So before we even have the interaction, they know what these social kind of negative connotations are, and they are already feeling and anticipating the blame that may come. And this is the type of stigma that may stop people from health-seeking behavior. So not coming to the doctor, not going to the emergency department, even though they know that they need help. Then there's internalized stigma where people really feel the shame. So they recognize, I am having these behaviors, I do have these conditions, but I'm really embarrassed and I feel really ashamed about them. And so therefore, I don't necessarily seek the care because I don't deserve the care. And then experience stigma, so the ways that in which people are actually discriminated against, which I think was kind of highlighted in those quotes that we went through before. And then on the other side of that, the sources of stigma, which can be social and community, but also the healthcare system and the staff, the structures, the laws, the policies. And so there's enacted stigma, right? Discrimination. So when our insurance will cover nutritional resources for diabetes and renal disease, but won't cover it for any other medical conditions, despite the fact that nutrition is really important, those are the things where we have enacted stigma. And then negative attitudes and prejudice, where we decide to not give people certain treatment options, or we treat them differently based off of these stigmatizing conditions. And so the consequences of these are that people experience restrictions in their social participation. They have increased morbidity and disability, poor quality of life and mental health, reduced access to care, delays in their diagnosis, and then poor treatment adherence. But I think the most important thing about this conceptual model is that it tells us about what are the things that we can actually try to do to combat these issues. And it looks at it from the patients and those who are stigmatized, and also from the sources of stigmatization. So from a patient perspective, I think it's really about empowerment, right? We're counseling patients, we're building their skills, we're doing things that empower patients to seek health care, to be active in their healthcare experience, and to be able to reduce the stigma that they feel around their condition because they understand it better. From a provider perspective, we need the information and education. So we need to understand, like one of the things that I do is I try to always educate people. Chronic liver disease is not all about alcohol. It's one reason that people have liver disease, but it actually right now is not the most common reason that people have liver disease. So information and education is really important. Also contact with affected persons. So, we all have these stereotypes and we learn these things, but sometimes we actually haven't had a chance to interact with people who have it. And so when we personalize these conditions and we can actually understand the backstories, it can give us a very different attitude about what it means to have a medical condition. And so looking for those opportunities. And then finally, talking about change agents and popular opinion. This may be things from like a structure, like organization structure level, laws and policies. So trying to kind of move within the healthcare system or even political systems. But change agents in this day and age can be social media and posting things and putting information that's out there. So it doesn't always have to be kind of the formal ways of doing things, but just getting information out there like we're doing with this echo. And so the importance here and how do we actually move this into our practice is let's try to create a shame-free environment. And one of the first ways we do that is by self-reflection. So what are your own personal biases? What are the things that you don't like dealing with and the medical conditions that really are challenging for you? And then how can you translate that into making it easier to be able to deal with this? Be very mindful of terminology. I think this is one of the easiest things, the kind of the low hanging fruit. You're even, with patient interactions, but also with your notes, with your colleagues, always using those terms that are going to remove the stigma from situations. So I would say from like in my clinical practice, I do not use the word alcoholic, and anything that I can do to remove that from diagnosis, I take those out. When I talk to patients about being overweight or obese, I try to talk about healthy weight, and I may refer to their body mass index, but I try not to use the terms obese or overweight, but still acknowledge that this is an issue and something we have to address. So I think terminology makes a really big difference, and is something that is not difficult for us to be able to implement. And then just practicing systematically. So every time that a patient comes in with a diagnosis, doing the same diagnostic testing, providing the same treatment options, unless there are true objective reasons that you can't do that. And then, specific to our health literacy, because we want to think about this in the context of how are we talking to patients, how are we presenting information so that they are empowered and they can understand it, making sure that the signage and the materials that we use are appropriate. So if they need to be in a different language because the primary language is not English, then making sure that we provide those and the information in the patient's preferred language may be something that's important. We want to make sure we're promoting within our staff a welcoming environment. So if we have a staff member who is exhibiting stigmatizing behavior, pulling that person aside and saying, this is not a place where that's going to be tolerated, and really setting the tone. Avoiding using medical jargon, and then encouraging questions, just encouraging patients to be as involved in their care as they can possibly be, because I think that's what helps them get rid of some of this stigma and be more engaged in their long-term health. And so I just want to thank Melanie for the opportunity to speak today. Stigma is something that's really important to me. And so when she offered this opportunity, I was very excited to be able to do this. And I hope that I've been able to meet those learning objectives and at least teach people one or two new things with this. And then I just wanted to acknowledge some of the funding that I've gotten both internally and through foundations and the federal government, which are allowing me to do this work. And that is the end of the didactics, and very happy to move to the question and answer portion.
Thank you very much, Dr. Brown, for this wonderful presentation. I really like it, and we have some questions on the chat. Dr. Stone, Melanie Stone. Yeah.
Yes, hi. Wonderful presentation, Dr. Brown. I have been learning so much from you in terms of stigma, and we've had a lot of discussions about this. I do have a question for you. I want to ask you about shared decision-making and its role in reducing stigma.
Absolutely. So that I think you know too that shared decision making is a big part of my research interest because I don't think that that happens enough, and I think that reducing stigma is really the foundation of being able to do shared decision making. So one of the things that is probably the most important to me is setting up rapport. So I'll give an example of saying, like, sometimes when I walk into a room, I can see that a patient has a very kind of negative attitude before we've even spoken. And so they're kind of already on the defensive about what I'm going to tell them and what this all means. And so sometimes I will just walk in and I will, after introductions, just ask them, I feel like there's something negative here. Do you want to tell me about what's going on? And it catches a lot of people off guard. But what I find is that having that opportunity to just say how they feel, what experiences they've had in the past, allows us to then talk about their diagnosis and make better decisions together. And I try to acknowledge, like, I'm not making decisions for you. We are making decisions together. And so I need to understand how you feel so that I can present you with the best options that are available to you, and then we can come to a decision. So I think addressing stigma is a huge part of having successful shared decision making.
Oh, thank you very much. I really like it when you say we are going to make this decision together, because there is a lot of a lot of emotions involved when a person receives a new diagnosis. It is a lot of that and that perhaps in that encounter. Thank you so much, Dr. Brown. I have also Dr. Cantu with your hand.
Yes, thank you very much. Thank you so much, Dr. Brown. Wonderful presentation. I just wanted to say my journey to understanding and trying to be more intentional about the language I use. A few years ago, I was touring our Haven for Hope organization here in San Antonio, which is the transitional organization that deals with issues around homelessness and transition, helping people transition. So the tour guide kept saying people who are experiencing homelessness, and that really started my journey into why he referred to it that way, and then being intentional and reflective of how I address it as well. And so I'd be mindful of that. I was wondering if you could share some of your journey that got you into this work. Thank you.
Absolutely. So I've had a similar experience to you with, I used to say homeless, and in working in a project where we were trying to treat hepatitis C, I came across someone who educated me as well as people experiencing homelessness. And that actually translated to me thinking, when I talk about patients, I try not to define them by their medical condition, but I say a patient with, this thing, but not necessarily that this is the thing that defines you. And I would say in my journey, patients have really taught me. I've made lots of mistakes. So our diagnosis, everything was alcoholic hepatitis, alcoholic liver disease. And patients would stop me and say, I'm not an alcoholic. Like, I drink 2 or 3 drinks, every day, every couple of days, but I am not an alcoholic. I work every day. I do all of these things. And so it was kind of having those interactions that helped me understand that something that didn't necessarily mean a lot to me meant a tremendous amount. And it was a barrier to me being effective in my treatment. So very early on, I kind of learned to listen to the patients and to try to change those terms, which were offensive.
Thank you. Thank you very much. I see Matthew.
Yeah, how are you doing, Dr. Brown? Thank you for the great presentation. I wanted to ask you, kind of pinging off of that point, I'm a clinician as well. I'm an internist. And as you know, so much of our existence is billing and coding.
Yes.
And we are in control of the words we use, but we're not in control of the diagnosis codes.
Yes.
When we see patients in the clinic or we print out an after visit sheet or anything, what is on there are those I've looked at your list of stigmatizing words, and it's pretty much all words that are official billable diagnoses. And so there have been times where, I knew a patient of mine, I do primary care, so I knew they were going to be upset if they saw the word obese on their after visit sheet. So I would put overweight, even though they were in an obese category. And then once they introduced BMI of this to that and whatever, are you aware of any national efforts that are being undertaken to try to address stigma in the way that we document in the medical record?
So yes, I am very familiar with that because a lot of times guidelines will change and our terminology will change before these ICD-10 codes. I don't know the formal of what is happening, but I can say that I do know it is happening because all of our diagnoses that were like alcoholic, they are now changing to alcohol related and alcohol associated. So I am starting to see some of those changes, but for things that are there that I have no control, I think very similar to you, I just acknowledge to patients that this is going to happen, that you're going to see this. That's the part that I have no control over. But if you look at my note, if you look at the communications that we have, that is, I'm going to put the words that I feel like are appropriate. And I've had a good response with that. Most of the patients understand that like those billing codes, we can't change. There's nothing you can do about that part, but just kind of addressing it head on.
Thank you very much. Dr. Stone, I see you have a question, comment, in both.
Yes, but I would like to give Elizabeth a chance, and then if after her I can go.
Okay, thank you. Elizabeth, thank you for joining us today. Do you have a question or comment?
Yeah, for Dr. Brown. Dr. Brown, I knew about a patient that she needed a transplant, liver transplant, and because she drank, they put her on a waiting list for a year for a liver. So as a recovery coach, I learned, and I put that into myself too about the stigma. So when I was taking becoming a recovery coach, what I did, because people, they play like how you're supposed to put yourself in somebody else's place. At the end of the day, I was like, well, where I fit here, because I love to drink. And they're talking about alcoholism, they're talking about use of opioids, they're talking about recreational drugs and all this stuff, how I fit in here. So as it turned out to be, every time, like you say, how many drinks you have a day, when you go to do assessment to any patient and to even us. So I was like, okay, well, what I'm doing here, that's what the teacher said. What kind that you trying to do the recovery for? But it got to a point that I just kind of meditate on it. And I said, well, I love to drink. So as I'm seeing this patient, because she disclosed that she likes to drink, they put her on a waiting list for a liver. At that point, I lost that patient. She's gone. But I now say, well, okay, I'm going to see, because if the alcohol, like you said, is being stigmatized so bad. So I just like, okay, let's see how far I can be without drinking, without social, that I can go somewhere. And because everybody's drinking, it's kind of social. And I did. I managed to stop. It's been 2 years that I didn't drink. And just because that patient, because I didn't want, and especially I do have some disabilities. So about the homeless, the way we are trained to set anyone encountering displacement, that way we will now use the homeless word. That's how you would approach these things? That I'm doing this the right way?
I think it's evolving, and so some of the things that I learned one year, it changes like next year, and so just trying to stay on top of it as much as possible. But also, like, if I use a term, and just being in tune to whether someone is having a reaction to that, and if they are, acknowledging it, apologizing for it, and trying to find a way that I can then repair that relationship and use a term that's better. I do just want to make one point about what you said with the patient, because of removing a lot of the stigma from liver transplant, they really are trying to remove some of the wait times for alcohol. So most of the liver transplant programs are not doing this 6 months, which is what everyone was learning previously. And so I would just say stay consistent in referring people, even if they have not had long times of sobriety, because we are seeing more and more people get transplanted successfully without relapsing and having major issues around alcohol. And that's a big priority.
Thank you very much, Dr. Brown, and thank you, Ms. Maldonado, for your comments and your question always. Now that we move to Dr. Stone, then from them, we want to go to our case presentation.
All right, I'll be quick. I think this idea of language and terminology is so important, both on an individual level and on a cultural and social norms level. So I was interested in the list, Dr. Brown, that you shared earlier, and I was a little bit surprised to see non-adherence on the list, because to me, I always learned that, you don't want to use non-compliant because that has an association that that person is making a choice not to adhere to their their regimen, their healthcare regimen, whereas non-adherence takes that away, and it's more about the circumstances that that person may not be able to follow through. So if non-adherent, can you explain a little bit why non-adherence is maybe not a good term and what you would suggest instead?
So what I have kind of learned from it, and this comes a lot from my experiences in transplant, is it's just one of those words that if people see non-compliant or non-adherent, then they think, okay, if you're not going to take your medications or you're not going to come to your appointments, then you are not a transplant candidate. And so if you see too much of that in notes ahead of time, like sometimes even before a person has an opportunity to come for a referral, those kind of things can be very negative. And so what they have kind of suggested is just describe instead. So like I will say a patient is not taking medication because they can't afford the medication that we prescribed. So we had to, find an alternative. Or we prescribed a 3-time-a-day medication and it's just not feasible because they're working and they can't remember to take that 12 o'clock one. So I think just in general, it's more about trying to explain the circumstance as opposed to labeling it as non-adherent. And I've also seen that it can come up in the problem list. So you can actually diagnose a person as being non-adherent. I think those are the kind of things that can create a stigma before a patient is seen.
Thank you.
Thank you so much.
Thank you. This is a great discussion, and please keep typing in those in the chat and as we go through this session. But thank you. This is exactly what Confianza wants to hear from you all, and we all learn together. If that's okay to you, let's move to our case presentation for today. Gloria Barrera present a case for today.
Thank you. Thank you so much. So I did want to just quickly give a shout out to Dr. Rosenfeld for sharing the Zoom background with me. Thank you. Again, my name is Gloria E. Barrera. I am a public health nurse and a nurse educator at a public university. School nurses, I did want to start off by saying that we are often the first line of health access for children and families, especially those new to our communities. Yet too often their role is misunderstood or overlooked. So with a nationwide shortage of school nurses, many students go without the support that they need to manage chronic conditions, access to care, or simply being heard. This case will hopefully remind us how vital our presence can be. So we can get started. As a quick background, I served as a certified school nurse in a suburban high school in Illinois with approximately 3,000 students and a growing population of newcomer students and families. Many of these families faced multiple barriers to care, including limited English proficiency, lack of insurance, and unfamiliarity with the U.S. healthcare system. So the case really does highlight how health literacy, trust, and compassionate navigation can directly influence access to timely and equitable care. So the scenario is a newly enrolled student visited my office, the health office, complaining of fatigue, weight gain, and difficulty concentrating. Through the conversation and review of recent medical records brought from her home country, I learned that she had recently been diagnosed with a thyroid disorder, but had not yet been taking her prescribed medication for several weeks. Her family had been unable to secure an appointment with a provider because they didn't have insurance coverage yet, and they were unsure on just where to start. So the language barrier further complicated communication, as her mother spoke very limited English and was unfamiliar with local healthcare resources. The family was understandably anxious, having received that diagnosis in Ukraine, their home country, but no clear guidance on how to manage it in a new country, in a new environment. So recognizing that this was both a health and a health literacy challenge, I began by creating a calm and shame-free environment, ensuring that the student and her mom felt heard and supported. Using an interpreter, I explained what the hypothyroidism was, while also being consistent with that medication, knowing that that was necessary, just sharing that. And then also what steps we could take together to restore her access to care. So I then helped the family complete a Medicaid application, walked them through the documents that were required, and connected them with our district's bilingual community liaison. Once coverage was approved, I assisted in scheduling that follow-up appointment at a nearby, FQHC, federally qualified health center, that offered the interpreter services and a sliding scale prescription method. So what went well in this scenario? It was first trust building, establishing that compassionate, judgment-free space. It really did help the student and her family feel comfortable sharing what they were navigating, and all the details that encompassed their situation. Effective navigation, so guiding the family through the Medicaid enrollment and appointment scheduling, it removed key barriers to accessing that necessary medication. What also went well was the health literacy in action. So using plain language, visual aids, and interpreter services really supported the understanding and built confidence, and collaboration. So partnering with the district liaison ensured sustained support beyond the health office visit. What went less well, in my opinion, it was system delays. So the Medicaid approval process took longer than I expected, leading to that continued gap in the medication access. Limited continuity. So after securing that appointment, follow-up relied heavily on the family's initiative. And it consisted of tracking within, my system, my school health system. That still remains a challenge. And time constraints. I would say balancing this level of individualized support with a busy daily caseload was extremely difficult, highlighting the need for dedicated staff for complex case management in schools. Again, there is a shortage of school nurses. So a key reflection here, I'm being mindful of time, it's 12:49. This experience reinforced that health literacy is not just about sharing information. It's about walking alongside individuals until they can confidently act on it. So by combining that empathy, the practical support, the system navigation, public health nurses, especially school nurses, can play a very critical role in bridging those gaps in care for our newcomer families. So I'll pause there. And I see the questions. Are those for me, or is it for the audience? I can answer them.
They're typically questions you have for the audience,
Okay.
But if you'd like to pose them, and we can just start the discussion, whichever you'd like.
Yeah. So one would be, how can schools, maybe in your community, in your states, how can schools and community health partners streamline Medicaid access to newcomer families?
Well, thank you very much. And I will use that question as a connection for our discussion. If is there any comment or question from our audience? And thank you so much, Gloria Barrera, for presenting this case, for preparing for us and presenting. And let me take a second also to give a huge thanks for Dr. Brown for the didactic presentation. I didn't say that before, but thank you so much. Dr. Cantu?
Yes, hi, Gloria, thank you so much. I was thinking that your name sounded familiar to me, and I know we both have done some work with Annie, so it's good to see you, and I hope you're doing well in Illinois.
Oh, good to see you.
Good to see you. In terms of this, what the schools can do, I think the schools are just what you were saying is that front line and open themselves up in so many different ways to connect with the families in a very trusting, non-judgmental way. And I think if the schools can continue to open up that pipeline and really be intentional about how to deliver messages to families, that the school nurses, everyone from the school is open to discuss not only school and education, but everything that promotes well-being, the environment, the issues around Medicaid and Medicare, because one of the things I've learned is that when the family is stressed out, so is the child, and that prevents the child from learning in the school. So I think anything that can be done to relay those messages to the parents, that they're perfectly willing to come to the school with any need, and it not just be from the educational standpoint.
Thank you so much, Dr. Cantu. And I'm going to read this comment from Dr. Stone. The school nurses are definitely a trust community health sources. Just definitely, it's a lot of work. Thank you so much. Is another comment? Or we can move to the second question. Thank you, Angela, for putting that in the chat. What system can support ongoing follow-up for students managing chronic conditions? Dr. Rosenfeld?
So I just wanted to share kind of here locally, and I don't have all the details, but I'd like maybe there's somebody else on the call that can share. Our county health district has a school-based health program, which is really robust. And in fact, they've got clinics on school campuses that serve both the student population as well as the community, which I don't think many people realize, that those clinics are not just for the students enrolled in those schools. And so part of the way that I know at least San Antonio, Bexar County is trying to address both the prevention of and also the better management of chronic conditions as well as mental health issues is through those school-based programs. So that's I think one of the more innovative things that we're doing here locally.
Thank you so much, Dr. Rosenfeld. This is very good information for all of us and that we can share. So there is another question here in the chat. Let me see. Well, before that, Ms. Maldonado, you have a comment?
Yes. Because I don't work with the system, but I know I have a lot of kids around me most of the time. How you can implement, especially because what is happening in school with mental health, how we can help, because some of these high schools or middle schools, they're using the mental health awareness courses as an elective. And I believe that it should be something very important, especially when they start high school. So how you doctors that are working in there, how we aside, how we can, because I know that's a tremendous need. So how we can help? I mean, you know that that's something that I must. So how that could be implemented, because I have grandchildren and they have to take the class, but it's an elective. They choose because they are using at the same time, they using the program where they will, Once they leave high school, they already graduate with their associate degree. So they use mental health as an elective for their curriculum. But how this can work with all the kids? I think would be so much great of good if
Thank you very
that
much.
could happen. Thank
Thank
you.
you. No, thank you so much. Thank you all. Any answer, comment from our host or another member in the audience? Any suggestion, any comment? Katie?
Hi. Oh, this is Donna Boudreau. I'm the neonatal program manager at University Hospital. I can let you know that my children, even from pre-K and kindergarten, their school counselor has them do a mental health check-in every day as part of the way they start their day. So they are aware of like, are we feeling good today? Are we feeling bad today? Are we, are we scared? How are we feeling? And so that mental health is not necessarily part of their curriculum, but it's part of their, something that they're familiar with at that early age. And that is something that is done across the school district that my kids attend. And so as far as them getting those same kind of daily check-ins, I don't know what happens in the middle school and high school levels, but it's definitely something that is exposed to children at the elementary school level, so that they build those skills from a very, very early age, and they're not afraid to talk about those feelings.
Thank you. Thank you very much. And just to respect everyone's time, we have a few more minutes and one question. And the chat is, how did you balance intensive navigation support with competing demands in your daily role? Anyone from the audience or the hub team would like to answer that question?
I'll address that one, and not because I have an answer, but because I think time is a lot of times the biggest barrier any of us have. I direct patient navigation services. We have 5 navigators of people living with breast cancer, and one of our navigators yesterday was telling us the number of hours she spent trying to clarify a medical question with the client's doctor that the client didn't understand. And she felt this tug of all these other clients that have, equally important questions, and the amount of time she was having to invest in this. So I don't have a great answer, but I think that is the biggest barrier.
No, this is very, very important. And you touched base on trust building that was also mentioned for Gloria. I see your hand. Gloria, do you have something to say?
Yeah, I did want to address what Donna said. So thank you for sharing your experience, your kids' experience. But I think that it's really important to note that that's not the standard across the country to have access to that amazing interdisciplinary team. So I am one of a team. I am a school nurse, but there are school psychologists, school counselors, school social workers, and we are all part of this interdisciplinary team. So it really is critical when we're supporting the whole child that all of those members of the team be employed full time in a school setting, and that their like students' access to them, it should not be determined by the zip code. It should be a right for every student across the US. So especially when students are navigating difficult health conditions, stressors, and these could even be mental health. I think that we alluded to that. We need to make sure that team is in place, because we wouldn't allow missing team members in a clinic setting, in a hospital setting, right? For there not to be this interdisciplinary team, on-call personnel. So that often does not exist in schools. So I just wanted to make sure that I highlighted that, to share that if if your child right now, those on the call, what is it? 54 of you. If 54 of you have kiddos, if you have nieces, nephews, what have you, making sure that they have access to these interdisciplinary team members. And if they don't, ask why not. Because I think that it's time that we start demanding it, because each of our role is essential to the success of a child's emotional well-being, physical well-being, and overall learning. And there's plenty of research on that. So I think going back to the question on how do you balance that, it's with the interdisciplinary partnership that I've developed, and making sure that we're also looking at outside of the school community. So community liaisons and the rest of the team members that need to assemble. So I just wanted to share that. Thank you.
Well, thank you so much. And just to respect everyone's time, thank you so much for this great case presentation, for the wonderful didactic presentation. I have one more here in the chat. It says from Dr. Rosenfeld, is that example is great. My boys are enrolled in a school at San Antonio Independent District, and they have been equipped with the skills and language since kindergarten to name and cope with their emotions. So important, right? So how we can start developing those skills. I invite you to join us, and for the following sessions for today is what we have prepared for you all. Thank you so much for these great presentations again, and thank you for you taking the time from your busy day and join us today. I appreciate that so much. Please join us, and the next session is gonna be in October 17th, and your feedback is so important. Please give us your feedback and claim for those credits and be patient with us. It's taking a little more time, but thank you so much, and see you next time.